Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Mr. Gwalither. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning. Good morning. Can you tell me about your problem? Doctor, I have had a skin lesion for the past 12 months. When I approached a local clinic, I was told that it is a skin tag. Do you have any pain? No, doctor. Any bleeding from the lesion or any trauma? No, doctor. I would like to evaluate and have a treatment for this. Okay, what's your age? 44, doctor. Do you drink or smoke? I'm a regular smoker, but drink very rarely. Where do you work? Actually, I do dynamite work, and in fact, putting in the dynamite in large holes for breaking ground for laying pipelines. I do frequent traveling for this work. Does anyone in your family have prostate cancer, kidney cancer, or any other illness? Nothing of such kind, doctor. Do you get fever? No, doctor. Are you positive for HIV, or do you have any STDs? No, doctor. Have you had any surgery in the past? Yes, doctor. I had back surgery with fusion of L5S1. What medications are you taking? I take Percocet occasionally for back discomfort. Are you allergic to any medicine? No, doctor. Well, your physical examination shows your blood pressure is 144/66, weight 177 pounds, your heartbeat rates and rhythm are regular. You have pedunculated lesion on the dorsum on your penis that is apparent. There is also another brown lesion mildly raised. Your testicles are bilateral and descended without masses. I think you have developed genital warts called molluscum contagiosum caused by human papillomavirus. The etiology is unknown, but it's most likely sexually transmitted. You have developed a viral infection that could have had a long incubation period. I suggest that from now on you have protected sexual intercourse to control the further transmission of the disease. Apply Condylox cream on the lesion for a period of 1 month. I suggest a CO2 laser therapy for the genital warts, which is just an outpatient procedure. However, there is a 20% chance of recurrence despite enucleating these lesions. Okay, doctor. I would like to go for a CO2 laser therapy.
Boy, age 10. Now take notes on the case history and current symptoms.
So your GP suggested you bring Tony in?
Yes, we've had a very bad night. He's had hardly any sleep, wheezing, out of breath and coughing. I was really worried, so I rang up Dr. Cooper.
Does he use a blue inhaler?
Yes, he's had one for years.
But it didn't help?
Not this time.
Is his asthma normally under control?
Well, he's had it since he was 4. I was worried about him going to school at the start, but he seems to manage most of the time.
Have you any animals at home?
No, he wanted a pet, so we got him a cat, but it made his condition worse, so he had to give it away.
Have you noticed if he's allergic to anything else?
Well, we try to keep dust down in the house.
Who did you see about Tony's asthma in the first place?
We were sent to St Mary's and he had lots of tests to see what he was allergic to.
And what were the results?
Oh, he was allergic to lots of things.
So he was put on Intal, was he?
Yes, he took that for years regularly, but a year ago his asthma got worse and our GP changed inhalers.
Does he now use a brown inhaler?
Yes, he uses it regularly.
Is there anyone else in the family with hay fever, eczema, or asthma?
Oh yes, my mother had asthma all her life. I had eczema as a child. On my husband's side, several people have hay fever.
Has Tony had any illness apart from asthma?
No, fortunately not. That's enough.
Has he ever had to come into hospital before with a similar attack to today's?
Yes, they put him on steroid tablets. Another time, he was rushed into intensive care and put on a machine to help him breathe.
Has he a nebulizing machine at home?
Yes, and a peak flow meter. The asthma nurse showed us how to use it.
What is Tony's usual peak flow rate?
300,
And what was it today?
100. He's been very restless all night and breathless. He took more and more puffs, but he's just the same.
Does anything special bring on one of these attacks?
It seems to be when he gets a cold.
That's very common. Well, Tony, I'm going to bring you into hospital to get you sorted out, all right?
Thank you, Doctor. That's a relief.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best, according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a nurse on an obstetrics ward talking to an obstetrician. Now read the question.
Excuse me, Doctor, could I have a word about a patient?
Sure.
In room 12, we have Mrs. Tate. She's a 35-year-old G3P3 woman who came in yesterday complaining of breast tenderness, bloating and mild nausea. Her last menstrual period was 6 weeks ago. She's married with 3 children under 5 and uses contraceptive pills for birth control. On physical examination, she is afebrile with a heart rate of 90 and blood pressure of 140/80. The urine pregnancy test has resulted positive, and transvaginal ultrasound reveals a 6-week size gestational sac with detectable fetal heartbeat. What's concerning me is that she's visibly distressed. The pregnancy was unplanned, and she's anxious about the emotional and financial implications. She was on bed rest for 6 weeks during her last pregnancy, and she's aware of the risks and difficulties of carrying this one to term. Would you be able to speak to her?
Question 26. You hear a senior doctor giving a group of medical students training in how to conduct a physical examination. Now read the question.
Today, I'm going to be demonstrating how to examine a patient's shoulder. So, you've taken a full history, which means you've got a fairly good idea what it is you're looking for, and it's time for the physical examination. Now, the thing to bear in mind is that the shoulder's an extremely complex joint, and there are many specific tests we can apply during an examination. Therefore, it's best not to jump to too many conclusions about the diagnosis. If you just go looking for that one thing, then you risk missing something else that might be there. So, how to conduct the examination? Well, you need to be organized and follow a set routine. The first thing is to ask your patient to remove their shirt or whatever to expose the area you're examining. Watching the patient do this is often quite instructive with shoulder problems because you can pick up whether they're actually guarding the shoulder as they do that. And that might give a clue as to the possible nature of the pain or exactly where it's located.
Question 27. You hear a GP talking to a patient about his mother. Now read the question.
So, how can I help you today?
I've come about my mum, actually. You know you referred her to the memory clinic.
Yes, that's right.
Well, the thing is, she went there and she's been diagnosed with Alzheimer's. I guess we should have known what was coming, but it still comes a bit of a bolt out of the blue, to be honest.
Oh, yes, I'm sure it has.
Well, Mum seems to be okay with it. It's me, really. I mean, I know what Alzheimer's is, but I don't know that much about it, really. So I thought it'd be best to come and see what I ought to be doing. My mum lives on her own at the moment, and she's coping fine, but how long's that going to be the case? Is there anything I should be doing? You know, is it going to get worse? I mean, do I need to start putting things in place to help her, or is that just going to alarm her? Is she safe to look after herself? Should I be looking out for certain signs or anything?
Okay, look, I understand your concerns. Before we go any further, though...
Question 28. You hear two nurses discussing a patient's care plan. Now read the question.
Shall we go over her care plan next?
Sure.
I'd say that the priority is some Lovenox training, because she's likely to be going home on that. She's been having a little bit of anxiety over this current hospitalization and the recurrence of her condition after a period of remission. She's a high fall risk, and she's also been in acute pain, but that's been well managed, so it's more about the anxiety.
Did you have to give anything for that?
She was okay without any pharmacological intervention, actually. We've been doing breathing exercises, and they're going well.
Okay. Anything else that we should be seeing to?
If she can show us that she's able to handle the injections, then we can go ahead and move to sign-off.
Okay.
Question 29. You hear a surgeon briefing his team before an operation. Now read the question.
I think this patient could be quite a problem post-operatively. Is he taking oral medications?
Yes, he's on phenytoin.
Okay, so if his gastrointestinal tract becomes unusable, we need to be ready to deliver that intravenously. The other issue with him is that from his records I can see that he's actually had quite a bad time in the post-operative period on previous occasions. He was a heavy smoker, but claims to have cut down considerably. Even so, he's going to have a larger midline incision, so he may be someone that you want to consider for an epidural, because he's likely to be at the extreme edge of the pain threshold.
We'll see at the beginning with the wound catheters and PCA. If necessary, we can do the epidural in the recovery room if he's in difficulty.
Fine.
Question 30. You will hear a dentist talking to a patient. Now read the question.
So we're going to fit your implant today. Have you had any problems since your last appointment?
Well, there was just one thing. You remember how hard you had to pull to get the impression off of my teeth once it had set?
Yes, it is a very tenacious material.
Well, the next day, one of my crowns dropped out. Look, I've got it here. Do you think that was what caused it to happen?
Oh dear, I'm sorry about that. I can probably refix it for you today if you want. These things do happen sometimes, I'm afraid.
Oh, thank you. That'd be great. But actually, what I was wondering was if I might have an implant instead of that crown as well. I mean, it's the second time it's fallen out, actually. I've had it years.
Oh, well, in that case, let's have a quick look at the tooth itself and see what might be possible.
Thanks.
That is the end of Part B. Now, look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1. Questions 31 to 36. You hear the lecture given by a physician on migraines and headaches. You have 90 seconds to read questions 31 to 36. Hello everyone. I am going to explain to you migraines and headaches. If you've given much consideration to the factors that might encompass the different types of migraine and headaches, You probably imagine that they range from a dull throb that doesn't require any treatment to excruciating pain that would require a trip to the emergency room. But do you know that there are about 16 different classifications involving migraine and headaches? Interestingly, some of them don't even involve head pain at all. Here's a rundown of various types of migraine and headaches. An abdominal migraine is mainly in children of 5 to 9 years old. However, it can occur in adults as well. This type of migraine usually doesn't involve a headache, although children with abdominal migraines often have head pain when they grow older. Acephalgic or silent migraine has many migraine symptoms but without headache. Alice in Wonderland syndrome is a rare form of migraine aura that causes distortions in perception. Patients with Alice in Wonderland syndrome might feel as if they are growing smaller, then larger, or might find time seeming to speed up or slow down. Usually, children experience this condition more than adults. However, it can occur in people of any age. Symptoms of a basilar-type migraine can be confused with those of a stroke at times. This condition can cause speech slurring, unsteadiness, vertigo, and numbness. This type of a migraine isn't common, but one study showed it may occur in up to 10% of those who have a migraine with aura. If the headache occurs for more than 15 times a month, means it's a chronic daily headache. About 4% to 5% of people have chronic daily headache, which falls into numerous subcategories based on the characteristics of the headache. A chronic daily headache will have symptoms like snore and sleep problems. Cluster headaches are the most painful headache type that involve attacks of severe pain lasting between 15 and 180 minutes. This can occur once every other day or even up to 8 times in a day. Cluster headaches are diagnosed more often in men than in women. Hemicrania continua is a headache that doesn't stop that occurs on one side of the head. Pain is moderate but can spike into excruciating at times. Hemicrania continua is not considered a migraine, but can share some symptoms with a migraine, including light sensitivity and nausea. However, the condition can be easily treated with a particular form of nonsteroidal anti-inflammatory drug. A hemiplegic migraine is a rare form of a migraine where the patient experiences weakness on one side of the body, possibly accompanied by confusion or speech slurring. Ice pick headaches are stabbing, extremely intense headaches that can be absolutely terrifying. The condition generally lasts from 5 to 30 seconds. However, they can strike anywhere on the head, sensing as if an ice pick is being stuck in the head. New daily persistent headache is diagnosed with daily head pain that persists for 3 months or more. To diagnose this type of headache, the doctor must first rule out several other conditions that can cause similar symptoms. Pseudotumor cerebri, or idiopathic intracranial hypertension, is a condition in which the body either produces too much of the fluid found in the brain and spine or doesn't absorb the fluid properly. Pseudotumor cerebri means false brain tumor because the symptoms of this condition mimic a brain tumor. A retinal migraine causes flashes or sparkles of light, possibly combined with partial or complete temporary blindness, but only in one eye. This occurs before the headache phase of a migraine starts. The head pain generally commences within an hour of such visual symptoms and lasts up to 3 days. A transformed migraine starts as chronic migraine attacks, however, gradually or quickly transforms into almost daily and less severe head pain. Transformed migraine attacks can be accompanied by nausea, along with sensitivity to sound and light. Status migrainosus is a painful, debilitating migraine attack that lasts for more than 72 hours. However, in case moderate to severe migraine pain lasts for more than 72 hours with less than a solid 4-hour pain-free period while awake, it should be treated as an emergency. A tension-type headache is the most common form of headache, affecting about 80% of people, which is often called a band around the head. In this condition, one will have mild to moderate pain that can be alleviated with over-the-counter pain relievers.
Now turn over and look at extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42. You hear a specialist in medical ethics called Anna Capstan giving a presentation on the issue of burnout in the medical profession.
Hi, I'm Anna Capstan from the Division of Medical Ethics at University College. Today I want to discuss the quite urgent topic of burnout among medical professionals as it's becoming. It's kind of an epidemic, but I really think that we're not talking about this enough. That's why we're here today, to get a bit of information out there and start a conversation. So, what is it? Well, burnout is a psychological and behavioral syndrome. Emotional exhaustion is one quite common hallmark of burnout. It's been defined as long-term, unresolvable job stress, a sense of being overwhelmed and depersonalized and lacking a sense of personal accomplishment. A recent study from the Mayo Clinic showed that in 2011, 45.5% of doctors reported that they felt burned out. And that number has now risen to 54.4% in 2014. More than half of all doctors in this country are saying, I really feel that some aspect of my work as a doctor is making me feel burned out. This is really trouble. It's trouble because a doctor who feels this way can commit more errors. They suffer from compassion fatigue, or just not being able to empathize with others because they have their own emotional issues. They may retire early, therefore reducing the workforce. They may have problems managing their own lives. 400 doctors committed suicide last year, which is double the rate of the population average. There's trouble for patients in having a workforce that's burned out. There's trouble for doctors in terms of their own health and well-being. We don't talk about it much. We like to think that doctors can handle everything, but it's clearly not true. It's a problem and there ought to be some solutions. One type of fix is to make sure that hospitals and other healthcare environments try to create better conditions for a happy workforce and for happier doctors. This might include yoga, mindfulness training, having more therapists to talk to, encouraging people to come forward when they feel this way, peer groups, and better mentoring. There are a lot of tactics that we could pursue and try to engage in. I'm not sure what's best, and maybe one size does not fit all, but it's time to really build a safety net so that we can keep our workforce functioning and we keep physicians at their careers and doing a good job, not making mistakes, not being indifferent to patients, and not harming themselves. This really is a problem, and we've got to attend to it in the workplace. It's just as important as any other aspect of workforce safety. When we institute new software, or when we have new bureaucratic regulations, I think somebody ought to ask, what does this do to the workforce? If one more doctor complains to me about Epic and other types of electronic record keeping and billing forms, it'll be one doctor too many. It takes a lot of energy, makes a lot of people unhappy. A lot of the software and computer assistance that's out there doesn't seem to help the doctor. It makes more work or makes them feel frustrated. It also seems to me that if you look at what's going on with respect to regulations and administrative or bureaucratic requirements, nobody is saying, hey, is this user-friendly? What's the burden that it's putting on the doctor? It's just done to save money or allow people to collect bills more reliably, but it's not asking what it's taking out of our workforce. I believe that morally, we've got to make sure that a highly trained workforce that takes a very long time to get the ability to practice medicine is a resource that we preserve and really take seriously. I don't think we're doing that as part of employee or workplace safety. I think it's crucial, but it's being ignored. We also have to view it as part of patient safety. And I think we should start spending some resources to figure out how we can make the physician workplace more user-friendly. How can we make it a happier place to be? What can we do to institute regulations, guidelines, software, and bureaucracy to try it out on the workforce for a while to make sure that they're satisfied and that it's not making their lives more miserable?